Bilirubin, total, transcutaneous. Bilirubin is a bile pigment produced through the breakdown of blood components. High bilirubin concentrations in the blood is known as jaundice. Transcutaneous bilirubinometry uses subcutaneous tissue photometry to measure bilirubin concentration, particularly in newborns. The optic head of the photometric analyzer is pressed against the infant's skin and takes several seconds to obtain a measurement. Hemoglobin, quantitative, transcutaneous. This test is a quantitative measurement of hemoglobin. One indication is the diagnosis of anemia or polycythemia in order to evaluate the severity of these conditions and to observe the patient's response to treatment. Measurement of hemoglobin by the transcutaneous method eliminates the need to draw blood. Instead, a visible and near-infrared spectroscopic device is used and measurements are obtained by a handheld probe, typically on the forearm. Hemoglobin, quantitative, transcutaneous, per day, carboxyhemoglobin. Methemoglobin. Carboxyhemoglobin is hemoglobin with carbon monoxide bound to it instead of the normal oxygen. Methemoglobin is hemoglobin that has been altered so that it is unable to carry oxygen. Methemoglobin may be acquired by exposure to certain chemical agents, or it may be due to a genetic condition. In vivo measures are non-invasive using visible and near-infrared optical bands. Caffeine Halothane Contracture Test, CHCT, for malignant hyperthermia susceptibility, including interpretation and report. The Caffeine Halothane Contracture Test, CHCT, is performed on freshly biopsied muscle for diagnosis of malignant hyperthermia, MH, susceptibility. MH is a life-threatening condition resulting from a genetic sensitivity of the skeletal muscles to volatile anesthetics. A muscle biopsy is obtained, usually from the thigh. The specimen is exposed to caffeine and halothane separately and the sustained muscle tension responses are recorded. Comparison of the strength of contracture, sustained muscle tension, for each exposure with previously established standards allows determination of MH susceptibility. Cell count, miscellaneous body fluids, e.g., cerebrospinal fluid, joint fluid, except blood. With differential count. CSF cell count may also be referred to as a CSF analysis or spinal fluid analysis. Joint fluid cell count may also be referred to as synovial fluid analysis. In 89,050, a manual nucleated blood cell count using a hemocytometer is performed on fluids obtained during a separately reportable spinal puncture or arthrocentesis. A differential cell study using manually prepared smears or a cytocentrifuge is performed in addition to the cell count. Depending on the suspected condition, a number of separately reportable additional tests may be performed. Leukocyte assessment, fecal, qualitative or semiquantitative. A fecal material leukocyte count is done on a stool sample by direct smear and stain to detect the presence of WBCs and aid in the differential diagnosis of diarrheal disease. Certain conditions are associated with marked fecal leukocyte presence, moderate numbers present, and the absence of fecal leukocytes. Fecal leukocyte absence indicates invasive toxic bacterial infection, giardiasis, or viral infection. Moderate and marked leukocytes indicate antibiotic-associated colitis, shigellosis, amebiasis, and salmonellosis. The methylene blue stain test for fecal polymorphonuclear leukocytes has a high sensitivity for bacterial diarrhea detection, but this test does not preempt the use of a culture. Crystal identification by light microscopy with or without polarizing lens analysis, tissue, or any body fluid, except urine. A fluid sample is obtained. A variety of different methods may be used to process the specimen depending on the source. The fluid is analyzed for the presence of crystals using direct light or polarized light microscopy. A newer technique using atomic force microscopy, AFM, may be available in some laboratories. Fat stain, feces, urine, or respiratory secretions. Prior to obtaining the stool specimen, the patient is placed on a diet containing at least 60 gm of fat/day. A random stool specimen is obtained. A small amount of stool is prepared with Sudan 3 stain and examined microscopically. A random urine sample is obtained. Urine sediment is stained with Sudan 3 or 4 and analyzed using light and polarized microscopy. Meat fibers, feces. An adequate intake of red meat is required for 24 to 72 hours prior to testing. A stool specimen is obtained. The specimen is mixed with 10% solution of eosin in ethanol and stained on a slide for 3 minutes and cover slipped. It is analyzed microscopically for rectangular striated muscle fibers. Nasal smear for eosinophils. 2 slides are normally obtained. Right stain is applied and the specimens are examined microscopically for the presence of eosinophils. Sputum, obtaining specimen, aerosol-induced technique. This is a separate procedure from the testing of the sputum sample, which is used to study airway inflammation in asthma and other respiratory disorders. Sputum induction is done to collect an adequate sample of secretions from the lower respiratory tract in patients who do not produce sputum spontaneously. This is done by having the patient inhale an aerosol of normal or hypertonic saline. Oral secretions or saliva are not a sputum sample and different protocols have the patient rinse and dry the mouth, spit into a separate cup, or brush his/her teeth and rinse before sample collection to avoid contamination. A nebulizer that provides sufficient output of saline aerosol is used. With patient cooperation, inhalation is done at regular intervals until enough sputum for a sample is expectorated or until the patient feels the urge to cough. Sweat collection by iontophoresis. An iontophoresis sweat collection test, also called a chloride sweat test, is done to diagnose cystic fibrosis, CF, in children. Iontophoresis is the topical introduction of ionized drugs into the skin using direct current/positive current is applied to drive positively charged drug molecules into the tissues. Sweat production is stimulated to obtain the sweat sample by placing pads or filter paper soaked in pilocarpine onto clean skin on the arm or neck. Positive electrodes are strapped over the pads. The circuit is completed by likewise placing negative electrodes over water-soaked pads. Low-voltage electrical current is left on for about 5 minutes to repel small amounts of pilocarpine into the skin. The electrodes are removed and the skin under the positive electrode is cleansed and dried. Pre-weighed filter paper is placed over the area and secured firmly with cling wrap. The filter paper is removed again after about 30 minutes, placed back in its bottle, and weighed again to calculate the amount of sweat collected. Iontophoresis may be repeated until enough sample is collected. It is then analyzed for chloride and sodium content. People with CF have an increased amount of sodium and chloride, salt, in their sweat. Concentrations greater than 60 mol/L are consistent with the diagnosis of CF.